So there you go. So we just Guayaquil. Simon Chan is from Guayaquil. Okay, perfect. So we're recording now. Let me see. Okay, Jeroen, welcome, and everybody, welcome. This is I hope this is one of many, and my initiative is to bring everyone together that is interested in freediving medicine and freediving science to put minds together and finally communicate and work as a group, perhaps. The idea is to make the sport better and safer, just like your initiative, your own, and Biso's initiative as well. So I'm very happy, and I care very much about freediving. So very happy to see you all together, and hopefully you get more attendance. Jeroen is a very experienced freediving medic and is coming here today to enlighten us with incident management in freediving. So Jeroen, welcome. Please introduce yourself, and the audience is yours.
Yes, thank you, Yanni. So hello guys, my name is Jeroen van Haudt. I work as an intensive care nurse in a large hospital in Belgium. I'm a passionate healthcare professional with a love for technical innovation, teaching, and freediving. I'm a former business owner in composite resins 3D shaping for the nautical and entertainment industry. So I wasn't a nurse, I haven't been a nurse all my career. I'm a volunteer and a full member of the AIDA International Medical and Science Committee, AIDA being the International Association for the Development of Apnea. A few years ago, I started Baranout. Baranout is a non-profit that promotes and provides aquatic safety and education. Among other, Baranout sponsors the Depth World Championships with medical expertise and material, as well as coordinating safety of actors who perform apnea during underwater video shoots in one of the biggest aquatic indoor film studios in Europe. Baranout has chosen to educate and work following the standards of then Europe, AIDA International, the International Life Saving Federation, and Universal Freedivers. And as a true universal freediver, I'm striving for the implementation of freedive-specific medical committees within every federation or movement. So we're busy within AIDA, we're busy in the Multi-Channels Medical Advisory Board, and we are trying to establish a freedive-specific medical committee within CMAS International. I'm also currently developing content and course materials for the Freediving Emergency Medical Responder course, the FEMER course in short. We're doing that for the diver medic as well as AIDA. We are aiming to educate the freedive community towards a better understanding of freediving specific pathophysiology and its prevention and management. The course consists of 3 different levels, of which the initial 2 certify the freediver as FEMER provider. The third and additional level certifies the freediver as an advanced FEMER provider, making it possible to comprehend and assist with freediving incident management techniques reserved for the advanced life support provider or medical doctor on site. In short, this presentation consists of my personal vision and beliefs. Today, I do not represent any group nor federation. I've put together a little table of contents. You're going to have to bear with me. I'm going to present you some facts about drowning, some facts about standardization and evidence-based learning. Then I'll present to you what we can do to the standardization on a core level, on a sports level within freediving, and on a professional level within freediving. So in between 2003 and 2013, we observed an exponential growth in depth with a dedicated semi-professional and professional freediving population. This was followed by another decade of unbelievable progress in certain disciplines. The following years, these depths also came within reach for the dedicated amateur freedivers, mainly because of study materials based upon the experiences of these progressives of the past decades. This has given the contemporary divers access to new training methods, to advanced equalization techniques, and more specialized gear. Contemporary reaching depths between 60 and 80 meters has become mainstream, and freediving agencies like AIDA International reacted by adapting their curriculum and incorporating and teaching these new techniques. Now all students gained access to greater depths. And at some point in our diving career, we leave behind our instructors and go out and join the freediving community. And a vast majority turns towards the internet, towards internet blogs and Facebook, threads as a source of additional information. That's a contemporary, logical, but dangerous evolution within freediving. You should know nobody goes on a dive with the intention of getting a loss of motor control or an hypoxic syncope, a blackout. Nobody goes diving with the aim of attaining pulmonary barotrauma or even sadly drown. So that, again, according to the World Health Organization, the definition of drowning is the following. I put it in front of you. Drowning is a process of experiencing respiratory impairment from immersion and submersion in liquid. It's the third leading cause of unintentional injury death worldwide, and accounting for 7% of all injury-related deaths. There are an estimated 236,000 annual drowning deaths, of which shallow water blackout, and that's the one important for us, the shallow water blackout alone is responsible for an annual 8,000 apnea-related deaths in the United States alone. So that's everybody who's swimming. We're not talking alone about freedivers. Those are just a few numbers, but it's a huge amount of people. 81% of these deaths are males between the age of 14 and 32. The 5 stages of drowning. The 5 stages of drowning start, according to the World Health Organization, you start with a surprise. In this stage, the victim recognizes danger and becomes afraid. The second stage of drowning is involuntary breath holding. The third one is unconsciousness. The fourth stage of drowning is hypoxic convulsions. And the fifth one is clinical death. When translated to freediving, we recognize several aspects of our beloved sport in these 5 stages. So technically and medically, if something goes wrong, we are immediately dealing with a potential stage 3 drowning. So it's correct to say that every freediving related underwater blackout is a drowning until further notice. Therefore, a pause in diving and a follow-up by a physician should always be advised. That's the case in every other drowning. We should adapt that way of thinking. Risk management should be imperative. To explain this and how we can manage the risk management, I like to use the Swiss cheese model. Some of you might be familiar with the Swiss cheese model of accident causation. It's a risk model that uses slices of Swiss cheese stacked side by side, in which the risk of a threat turning into a reality is mitigated by the different layers. So the goal in any human system is to ensure that the holes in the layers never line up, so that threats can never penetrate to the next layer. Eliminating immediate and underlying causes and working towards a safer sport practice is vital. Therefore, risk management is a more realistic term than safety. It implies that hazards are ever present, that they must be identified, analyzed, evaluated, and controlled, or rationally accepted. Risk management in freediving should become the new rationale. And I realize we have a very safe sport, and some of you might find the way I approach this subject a bit over the top. Nevertheless, I believe firmly that by adapting a few standards in freediving incident management, we will create a better awareness of what it is we are doing. I hope that this awareness will create a general change in how all of us who perform apnea diving regard our activity. So, are you still with me? Standardization.
Yes.
We chose the subject, and I wanted to, how can I say it, make it very broad and not dive into very medical, scientific terms and terminologies for this first session. So I'm going to look at standardization, like I told you in the table of contents, to the whole freediving community. What can we do to standardize and to follow other sectors of our community that already standardized their activities? What does standardization actually mean? Standardization is the process of developing and promoting and possibly mandating standards-based and compatible technologies and processes. It's a whole mouthful, but it is what it is. In this case, we apply it on freediving. What's the difference between a standard and standardization, you might ask? A standard is considered to be the best way, while standardization is the process by which the standard is established and improved upon, which is very important in my opinion. So standards for safe practice or rescue protocols ensure compatibility, interoperability, and safety. I'm sorry. To create quality of care and to create specificity of care and to facilitate research. In other words, to set up international performance standards to reduce misunderstandings in communication in our international community and to allow interchangeability of medical team members while maintaining high quality standards. Because that's what we strive for, the best possible standard of care to manage freediving incidents worldwide. Managing this complexity through evidence-based standards. Standardization of incident management actually starts with prevention. That's where I want to get to. Prevention is the largest piece of standardization. This consists of two categories. The first one, gathering information about incidents within the official competitive circuit and gathering information from our broad base of amateur freedivers. Processing this data could lead to concrete evidence-based learning. You can manage complexity through evidence-based standards. The availability of accurate and timely and comprehensive accident and incident data has been a long-standing issue already. You get the best possible evidence, you get to do regular reviews, and you get comparative data. And this nowadays has been done just by collecting information from official events. So I'm striving to implement a new approach to this, which would be an individual incident report. It could be a simple Google form, compliant to the General Data Protection Regulation. I'll get back to this a little bit further. But standardization also brings innovation. Yeah? First, because it provides structured methods and reliable data. that saves time in the innovation process, and secondly, because it makes it easier to disseminate. It leads to edging techniques. Safety-wise, you can look at Octopus. Octopus has taken every piece of kit in this field, in the field of safety gear, and upwarded it. Evidence-based standards and guidelines can provide support to doctors, so in our care, in the medical sector, in making complex decisions and help them to avoid medical errors and omissions. To contribute to the realization of a safer freediving environment, we should apply the principle of standardization on all levels of the freediving community. And some aspects are already in place. Others need to be added or emphasized. It's all about building experience, in this case, preferably without someone needing to get hurt. How to overcome the skills gap. It aims at 3 levels, standardization, consisting of different approaches. The core level. Within the core level, we will look at non-technical skills and the human factor. We will look at the stay and go principle. We will go over the oxygen first aid, and we will come back to the individual incident report. The non-technical skills, we aim for prevention through participation. The moment we expect, for my English, participation, you should take the human factor in consideration. We apply human factors in the medical sector. Juani and Bizo will definitely know, or some other ones of you are professionally involved in the medical sector. I would like to see it happen a bit more in freediving. It aims to build awareness of the importance of non-technical skills in making changes to improve safety. So they are interpersonal skills, non-technical skills. Communication, leadership, teamwork, decision-making, situational awareness, time management, they're all in there. You'll see where I want to get to. Communication before and after a dive. So the briefing and the debriefing, there are curriculums who teach this, but I see it happen on very few occasions that actually there's a briefing and afterwards a debriefing. What, where, how, and who, division of tasks, listening to one another, planning your dive. Learn to plan your dive. Why? Because creating a shared mental preparedness state wherefrom the individual and the team can benefit, with a focus on individual, physical, and mental preparation. So, in my opinion, freediving is often wrongly perceived as an individual sport. Whether you take a dive trip to a local lake in Holland, or you go for a personal best of 80 meters in the Blue Hole, it's always a team effort. Freediving is a team sport. Within this team, you should always apply the emergency rescue plan. Everybody should know where the entrance is and the exit. What are the target depths? What is the target depth distance? How far do we need to swim? What are the time frames? What kind of rescue equipment do we have on location? Did we check this equipment? Do we know the local emergency numbers or the address where we need to go to? And in this case, again, if something happens and we need to go, should we stay or go? Now with the current curriculum, our education stops with towing to the shore. And even the fashion this towing is executed is ready for revision, in my opinion. So in case of an incident, do we have a conscious and a responsive diver? Can we stay? Or do we have an unconscious, an unresponsive diver? Should we apply blow tap talk? We've been discussing this within AIDA. It's not scientifically proven that blow tap talk helps. Should we stay using this? Should we keep using this? I'm sorry, because it only takes time. If we decide to go fast, my opinion, new standardization, no dynamic rescue breaths are necessary. It is scientifically proven that if you go from point A to point B, so from the diving distance towards the shore, giving breaths, rescue breaths while you are towing has no use. It's better to go fast. So a new standard would be nice. Another change in standard. Nowadays, we all, from 4-star and up, we all need a prerequisite of first aid. And we need our basic life support, CPR, with the use of AD, plus a first aid certificate. This we have to renew every 2 years from 4-star and up. Standardization at a core level could mean changing the prerequisites for freediving certification. For example, if we would change the mandatory first aid certificate, which consists primarily of wound care and bandages, into a mandatory oxygen first aid, so OFA, we would create a much larger awareness towards freediving incident management. On this core level already, people would start to make sense out of this experience, engaging further exploration of the subject. So that's what we have to do every 2 years. We could change it into the second one. We could add oxygen first aid to our BLS.
Hey, Jeroen, would you mind if I ask you a question?
Yeah, sure.
I feel like I'm hearing an echo here. Is there a way to mute this little screen?
From me?
Yeah, it looks like I can hear an echo. That's okay. Do you find that the first aid standards are much different between countries or continents, since you mentioned first aid?
Well, wait, I'll try to. You say something?
Yeah.
No. I want to use my headsets to avoid the echo. But anyway, that's for later. Yeah. Your question, yeah, the standards, of course, they are different, but it's not about the standards in detail that I'm talking. If we would create a new standard, and in this case, in our first aid, our mandatory first aid, I know out of experience that nobody, when they do their recertification, actually is doing the bandages and is doing the first aid part of their certificate. They're not using it. It would be much better if we would just cancel that and change it with an oxygen first aid. The oxygen first aid is the, how do you say that in English? It's the first step towards becoming an oxygen provider and later on becoming an advanced oxygen provider, which in our case is much more useful if a broader percentage of our community would have this knowledge from early on in their trajectory. So standardization of incident management, prevention-wise, this could be a solution. I don't know if I have answered your question, Yanni. Of course, there are different settings, and even the wording, the terminology is different.
Okay.
You have medical first aid, you have first aid, but basically what the federations or organizations ask of us is to present a certificate that you know CPR, that you know how to use an AED, and that you have knowledge of first aid, being general wound care.
Perfect. Thank you.
That's just my proposition, my ideas, among others, one of the ideas that I had. So modifying this standard could have major consequences. How to approach a diver in continuous respiratory distress. A lot of people actually don't know how to handle this, how to use an oxygen kit. From that comes the logical question that they will start posing themselves. Can my body dive tomorrow? If they have this little bit more knowledge about what's actually happening, they will make saner decisions. This knowledge would ultimately change the view of the core diver, the broadest basis of our community, all those divers everywhere, on the experience of this sport. So yeah, while answering your questions, they need to be presented every 2 years. So the layman needs to recertify every 2 years. So in my book, that's even too little, but that's the standard. So we have to comply, but we could change the content. And maybe the oxygen first aid arouses more interest among free divers in general.
Thank you.
Another one, collecting general data of individual member incidents. We are 30 years into ADA, 30 wonderful years, but still no database. There's no database of individual incident reports. It's non-existent. So wouldn't it be wonderful that finally, after 30 years, we would be able to collect this kind of data? Again, the evidence-based approach, collecting general data, compliant to the General Data Protection Regulation, of course, in the form of a Google form. And instead of focusing on incidents during official events, because those forms exist already, we could broaden this spectrum and collect data from as much incidents as possible. We could collect the level of the diver, the nature of the incident. We could collect complications, result, reaction, and precaution were taken. Thus being able to determine not only the severity and approach of barotrauma, but also, for example, to the efficacy of our courses. We really, really need a broader base, a broader evidence base to not only change our curriculum, but also learn scientifically. There's too little data. It's going too slow. The divers are going fast, they're going deeper and deeper and deeper, and we can hardly follow as medical professionals.
Hey, Jeroen, quick question. Do you feel like the incidents are perhaps underreported, which is my opinion, but what do you think about this underreporting the incidents among athletes?
Yes.
Mea culpa, I wouldn't tell myself, you know, go ahead.
They are for sure underreported. Because there's no culture that you should report it. There's no way to report it. So why should we even bother? If there would be a way, people would at least have the choice to fill in the form or not.
Right.
But yes, certainly it's underreported, and it's part of the culture, because a lot of divers out there don't actually, even to their buddies, to their closest team members, in my opinion, because I talk about a team sport, even to those people, they hide their symptoms, they hide the fact that something is going wrong. So we really need to be able to create a community that is pro reporting. We need to change their state of mind, that it is okay to have an incident. It's, of course, it's part of the learning curve. We all know that, but it's okay to talk about it.
Yeah.
Of course, the only consequence that would have would be the time off that they have to take, because that's the reality. If you talk about what happened to you, you need to consider taking time off, and that's what they don't do. They just keep diving.
Yeah.
So, the way you were working towards the severity scale, that would also be a very helpful tool for this, to give the community a guideline for them to determine what is actually happening to them. Is it okay to dive tomorrow, the day after, or should they stop for a week or 2 weeks? Or so standardization with forms, with Bizo was working on something as well with the pulmonary edema. We need to work towards standardization, and out of that food of thought will come useful things for the society, for the community. I'm sorry.
Yeah, well, it's just a quick add-on. So it's difficult because we're all free divers, and anything that will stop us from enjoying free diving it sort of comes in the way, So yeah, in my case, if I feel something's maybe wrong, I will try to block it and still try to free dive. So I will include myself on the mea culpa,
Yeah. I want to point out to the other listeners here that afterwards, please, if you have questions like Yanni has, please ask them. Please remember them and ask me afterwards. I don't think it's if I'd say to you that we could have a discussion, but I didn't think that was the format now. But please ask your questions afterwards when I'm done.
Thank you.
But yeah, to give an example, I have done an apnea academy instructor course in Tenerife, and I had an otitis external. So I had an ear infection external, and it was hurting like hell. It really bothered me, and I could have finished the course. But being who I am, and having, in my opinion, the exemplary role that I wanted to perform, I did not finish my apnea academy instructor course then, because of the otitis, because I needed to stay out of the water for my own health. So exemplary, I did not finish the course. And it's really, really hard because you pay for it, you travel for it. And I can understand why people keep on diving. But at least if we can give them more knowledge of what actually is happening to them, maybe some percentage that need to take a different decision will do so in the future. So combining the go fast principle, to come back on what I was saying, with a new oxygen first aid standard certification, this would create a much faster and efficient chain of response in case of an incident. That's, you see what where I'm working towards. If we would give them more tools that are mandatory, there would and will grow a change in case, because we're always talking about incident management. Yeah? In the aftermath of the incident, with a cup of tea, a debriefing could take place between the divers involved. An incident report could be prepared. It's just that. It's just not the habit. It's not the culture to do that. And I'm not talking about everybody, because I know certain divers, like in Dahab, who actually do this. But sadly, it is only in the case when something really severe has happened. Why not do it with ordinary pathologies? Why not debrief this? Why not discuss this? What happened? What went wrong? How did it come this far? And then an incident report, an individual incident report, could be filled in and uploaded. And in that way, we would create a database that would be really, really useful. We'll try to accomplish this. Hey, Yanni? So yeah.
Yes, thank you. Go ahead. It's great.
Freediving emergency medical responder course. Level 1, the first level within the core divers. This FEMUR course aims to create a freediving specific 3-level medical responder course, running simultaneously next to the main freediving courses. So we would start early as possible, as early as they are interested. We could give them this extra bit of information. In that way, hoping to inform and create a more risk-aware and risk-free freediving community. That's actually what we just were talking about. Within the first level, within the core level, within this FEMUR first level, we would teach this adapted algorithm. I've adapted some algorithms out of emergency care, specifically for freediving. Why? Not really to be mandatory, because we have our ABCDE approach, which stays primary. Of course, we don't want to miss out any other pathologies. For instance, an anaphylactic shock or anything. We don't want to rule out that can be the case as well. But teaching specific algorithms makes clear what actually must happen. The speed is the word I was looking for, how to react, and looking at it to it. You see 3 out of 4 blackouts are treated by an advanced medical team, in my opinion. So that's fast, that's happening, reaction, transport, and management. The second diver level is the sports level. I regard all divers who are a little bit more experienced, who have learned some techniques, who are attaining deeper depths on the sports level. Within sports level, human factor and non-technical skills are equally important. It is equally important to keep educating our divers by means of the FEMUR, the second level of the FEMUR. The human factor in this is understanding cognitive workload and its effect on athletes become very important when you are upping your A game. It's actually really stressful. We all know what happens when we go for this training, when we want to attain this depth, when we want to progress. Too much pressure and demand causes overstress and reduced human performance for the performing athlete as well as the surrounding team. So again, the human factor is very important. Plan your dive and dive your plan. That's out of scuba diving, but it's the same for us. When training, use what you learned. Plan target depth, surface times, use your computer. It's what it's for. And aboard whenever necessary. Communicate within the team. Standardization of education. That's another evolution that we're seeing. Our friends from Vertical Blue, Marco Cosentino, is doing the in-water safety. It's specialized and very specific. It's a course that teaches incident management in the environment. That's what we were missing. The femur just follows this up. It's specialized, it's specific, it's out of water safety. Together, combined, they're very powerful tools for those divers who are interested in performing incident management. Again, within this level, there are a few algorithms that point out the necessity of acting faster in the hypoxic state. These I teach in the second level. We have an advanced medical team algorithm, which is very freedive specific based on the stay and go principle. Another one is the rhythm assessment. It's the same. We all always keep the ABCDE approach in the back of our minds, but how do we do this in an aquatic environment? How do we do this with a free diver, with an incidented free diver? Then we come to the pro diver level. What can we do to attain some form of standardization on a professional level? I could have done a whole lecture just on this level, competition-wise, but I've chosen it, especially chosen to make it broader, to make it more useful for everybody that's listening. The pro level, we use the standard medical rescue protocol. That's a document that has been made up years ago, which gives clear language and definitions. An introduction of non-technical skills, mandatory advanced life support providers as medics, detailed and clear material lists. It's really worthwhile to make this document more accessible for every diver and not just for the competition medic. There's a lot of useful information that goes into these kinds of documents. There's a lot of research and discussion going into these documents. Volunteers within the Medical and Science Committee have committed their time in creating documents that are really helpful in the standardization of freedive incident management. And I firmly believe we have to get it out there. You should know that those documents, of course, are primarily, to support organizers of competitions with the best available information. Event medics ultimately assume responsibility for all medical decisions. Again, within the pro level, there's the level 3 of the femur. Here we go deeper into the pulmonary barotrauma and guidelines, how to react, how to go and go fast again. Again, also with ABCDE in the back of our minds. Only this developed incident management algorithm will take it a bit further. It are also recommendations, not mandatory. Within the pro level, I would like to share with you some equipment. I think everybody who's interested in the medical and the rescue part, the safety part of freediving, everybody who owns an oxygen kit, should own a CPAP, but a Venturi valve. It's just a little device that you can connect to your oxygen bottle, which creates positive pressure. Within freediving, and I've put it in the pro level, but also useful for every kind of, especially when you need to transport your victim, not necessarily a pro diver, can be anybody. Secondly, from Vigon. There's the B card. It's actually the same principle. It's a resuscitation valve. You can connect it to your oxygen bottle while performing CPR. You administer 100% oxygen every time you compress, and you, how do you call it in English? You let go of the compression, you come up, oxygen is administered. This is extremely useful in contained environments like inflatable rig, for instance. If it's the case that you cannot balloon and do compression in a small rig, in a rib, almost impossible. You need a spine board and you need enough space. This device, just 2 devices, put them in your oxygen kit. It's worth it when you have them with you. Standardization for our basis could mean changing the prerequisites for freediving certification. Yeah, to contribute to the realization of a safer freedive environment, we should apply the principle of standardization on all levels of the freedive community. Today's presentation, it was a little bit of an introduction on how to apply human factor in freedive, how we can use non-technical skills to better perform in the aquatic environment. Because risk management reduces the chances of an incident happening. It reduces stress. Risk management is a team effort. This mental state of mind will help us to dive deeper in ourselves. And yeah, it was a whole lot. I want to thank you all for taking time on this Sunday to listening to me. I'm not a native English speaker, so I had a little bit things written down. I hope I've, how do you say that, transmitted something to you. And if any of you have questions, I'm glad you want to hear them. Thank you. I'm
sure we have a bunch of questions. Jeroen, thank you. This is great material, and I mean, the algorithms you put together are just essential. They are landmark. I think it's landmark information for the community. I have a couple of questions, but I'm gonna let the audience first ask you some questions. I believe Ollie is here and he has a question. So Ollie, go ahead. It's not seeing you.
Hey, thank you, and good to see you guys. Sorry I was late. So I missed the first 15 minutes, but that was very interesting already what I caught there. So thank you very much, guys. First of all, yes, oxygen provider plus first aid, absolutely necessary. We're working on that to make it compulsory in Vermolchanovs from wave 3 or equivalent ADA 4 upwards, with the only restriction that in certain countries it's not possible, like Thailand, for example, that you have to be medical personnel to be allowed to administer oxygen. So there will be this exception, maybe also other countries, which we have to figure out. That's one comment. Strongly support that proposal. The second thing is reporting or having a database of incidents. That is compulsory in Molchanov as well. Every instructor has the duty to report, and we treat this as an essential part of quality management, actually.
Yes.
And it's quite interesting to see what kind of reports we get, like sort of a totally inexplicable LMCs in a first open water session with a beginner, and the instructor is totally baffled and doesn't know what happened. That's the interesting cases that we use now for more like a educational level, that we can start a conversation with the instructor, try to find out what happened, and it's always the beginning of a very fruitful conversation. It's not used as a database yet because of the European laws that have changed a few years ago. We didn't dig into that yet. what we are allowed to register and in what ways or so. But for purely education purpose, so far, a very helpful tool. And I really hope we can establish this in every agency as a culture of quality management.
Yes.
So thanks again, guys.
Thanks, Ollie. I'm happy you didn't have a difficult question ready for me like you announced.
Not this time.
That is,
Next time.
yeah, all right. Let's keep in touch about this incident reporting. I'm curious how you are doing it, Molchanovs.
Absolutely.
So
If
anybody
I
else?
may intervene, yes, it's Peter here. Just wanted to congratulate very straightforward presentation, very clear. So don't mind your English. That's never an issue in this case. It was very understandable. I wanted to add to what we were speaking about, the reporting. Maybe you guys can take notes. I know sometimes I filled out like a simple survey on a Google platform of some sort, where it doesn't have to be something overwhelming for the instructor, right? Because I'm guessing a lot of incidents that occur are very minor, and that's where the other part of this question or this comment would be is the severity of the incident, right? So at the moment of making a report, it should be something that's not overwhelming for the instructor. It should be something very direct, very precise, but more is less, they say. But how much do we actually need to inform? And obviously, details are a great part in this in this field of medicine, I would say. So maybe starting out small and seeing where this can take us as far as collecting data, right? Start out with a basic little survey, Google based, I don't know, is it like a blog? I remember, in my university, we used to fill out some surveys, and that's where we would input information. It's very precise, and it's something that you can make accessible to everybody. So maybe you guys can further look into this, or I can further help and get more involved with you all as far as collecting data. But definitely it's something that needs to be done, and standardizing is the key point that I'm taking away from your presentation. Standardizing the severity, standardizing what to report, when to report. This is extremely important in this case. And I thank you for this presentation, to be honest.
Thank you, Peter. Appreciate it. Thank you for your words. And I totally agree. I would even take it a bit further, and that this incident reporting isn't solely for instructors. It should be for every diver, every buddy pair, every team of divers that went out there and that had an incident. If we could create a culture where they would debrief, where they would talk about what exactly happened during their session, and then they could indeed just fill in a simple Google form with the rudimentary data that could be of use for us within a database. That would be a large step forward. So yes, I agree totally. Yeah, thank you.
I feel like it's a great I feel like it's a great initiative, and yeah, standardization is huge. I feel like ADA has a no report form, but usually the variables that you want to look at are things like age, for example, discipline, depth, if the blackout was underwater or out of water or surface, or if there's dyspnea or desaturation. I will show you guys on another time, but I recently presented a poster at the UHMS meeting looking at the severity scale, which is something like it would serve as a purpose of communicating in the future. Like if, for example, somebody had severity 4 versus severity 10 versus 12 in the past, and how recent was the issue, then that's important. And you brought up this point, Jeroen, what is the recent history of a diver? If a diver has had a barotrauma in the last month or the last 3 months.
Yes.
I feel that's a good point that you brought up. Go ahead.
Yeah. Yeah, well, we talked about that several times, but indeed it is but then we're talking very specific as a medic. If you're a medic and you are attaining some kind of competition, it's really important that you do your research. You're not there for front row seats. You have to know from every diver what has been his history like for the last 6 months, of course, if you can. And that's, again, this culture, and I can understand within a professional level that you don't want to get it out there that something has happened to you. But at least you can see as a medic, because the biggest competitions are recorded, you can make for yourself some notes regarding who did what, who did a underwater blackout, who did several surface blackouts, and that way you can diagnose faster again with the go fast principle. The more information you have at hand as a medic, the more accurate you can intervene and manage your situation at that moment. So the severity scale, really looking forward to that one. I would like to add that indeed the incident report that is being used now by ADA, there is a project to broaden this. ADA is working, the Medical and Science Committee, they are working on a way to collect more data than just the data that is mandatory by the events organizer, because that's what it is. Up until now, the incident reporting is a mandatory list that needs to be uploaded at the end of an event. It contains only blackouts, surface underwater, barotrauma, some major incidents, and that's it. It doesn't include divers information regarding age and that kind of things, level. So yeah, a lot of work also there to be done to create a broader database, but surely we'll get there.
It looks like we have more hands. Go ahead, Matthias, right?
Matthias, yeah, I have a question here, or several. I see that you mentioned that should go away from a low tap talk, and I was thinking, is that due to that we would usually have more and more oxygen therapy on our hands? And if is there any difference between depth and pool when it comes to low tap talk?
Yeah, definitely a difference between pool and outdoor diving. That's for sure. In the pool, mostly they regain consciousness rather fast. But then again, if you look at the blow tap talk movement, how do you say that? The complexity, you blow, you tap, you talk, but you remove facial equipment. By touching the face, removing facial equipment, you touch. You talk. Talking is good. Talking won't kill anybody. But it's just the fact it takes a whole lot of time to execute a blow tap talk. And you see it regularly that it has been, they perform it like 2 or 3 times in a row. So they start blowing out across the nose, they start tapping, they start talking, but nothing is happening. And that's because everybody wants to execute this blow tap talk. Blowing, it's not scientifically proven that it does help. We know that we have the receptors there and it has been an ongoing discussion. But in any case, the blow tap talk principle isn't proven scientifically that it helps. It isn't proven that it doesn't help as well. But I know one thing, it takes time, and it takes off precious time, especially with those coming up from depth, from the deeper dives, you have a hypoxic brain that is crying out for oxygen, indeed. So I would rather see the time spent for a second blow tap talk that they are already doing transport. You just give 2 rescue breaths, nose or mouth, and if there's no reaction, immediate transport. Why waste time touching somebody's face, blowing across somebody's face while they actually need oxygen? The brain needs oxygen. So I am strongly pro no more blow tap talk. But that's, again, that's my vision. That's because I'd like to see a shift in approach towards a go fast principle. I hope that answers your question, Matthias.
Yeah, so as I see your answer is that in pool, it's definitely worth trying, but short, and then faster getting into the next step in the rescue. And when you go in depth, it's more important to be even faster and preferably having the oxygen therapy just next to it and have some platform just to push the person up on.
Because you have to, the most of the things that I base my opinions on is on the core level. Most of the divers out there dive from a buoy, certain distance from the shore before attaining their target depth. So it's a 5, 7, 10-minute swim for most of them, or boat ride. So when an incident happens that is going, a grave incident, I think you say that in English, eh?
Yep.
In the pool, you immediately are at a quay, poolside, and you can act. But mainly when diving in open water, there is the distance to cover. And then again, it's not even sure that when you reach the shore that you have access to proper rescue equipment. So the faster you react there, the better. So the blow tap talk in depth, I'd like to see that go and create a different mindset.
Just an additional question there. If you look at the water rescue statistics, they prove that usually that if you do 5 to 7 rescue breath already in water, it's much more likely likely to survive a drowning compared to if you just take them onto shore directly.
Well, I'm totally pro 5 rescue breaths. We are dealing with drownings. You give 5 rescue breaths, preferably with oxygen. Totally pro. But then if after 5 breaths, your diver does not regain consciousness and you have to cover 80 meters towing to shore, you just go. And you do not stop every 10 meters to give a breath. You just go and you execute the tow of 80 meters because they have no effect whatsoever. It's been proven. There have been within the International Life-Saving Federation, the question was raised for lifeguards whether to execute these breaths while towing their victim. And survival rate was much higher for those victims that were immediately transported towards the shore. So the faster you have access to proper medical intervention, the higher likely the victim's chance of survival. So I'd like to see that principle.
Thank you for that answer. I'm very clear what you mean.
Yes, I'd like to see that principle applied in freediving.
Hey, Jeroen, so I feel like you did a good differentiation between surface blackout and underwater blackout, because if it's a surface blackout upon ascent, I feel like the majority of what is considered a mild blackout at least per AIDA guidelines, recover with blow tap talk or blow talk, but rather the other option is the underwater blackout, which usually is associated with respiratory issues. Then doing blow tap talk may be a waste of time, and you rather get that airway out of the water, And as we know, every time the airway comes out and comes back in the water, the recovery of that blackout is extended, so it's longer. So you did a great differentiation between both.
Yes.
That's all I'd say.
Yeah, but indeed that's the case. But then again, I've seen some surface blackouts that were really ugly. So that were actually having hypoxic convulsions, epileptic seizures, and they were blackouts. So it is always up to the safety divers in the water and the medics out of the water to be able to determine and assess what actually is happening, and to choose the best way to approach the incident at that moment. And then yes, standardization will help us do so. Yes.
Yeah, Rick Roskin brings a good point that, like you said, a surface blackout, which is considered mild, may be complicated with prolonged hypoxia due to a squeeze or respiratory barotrauma.
Yeah,
that's correct. Yeah, well, and
hi, Rick.
George has a question.
I don't know if you're talking to me.
Yeah.
Hey,
yeah,
George.
Hello from Cyprus.
Hola, George. Hola, kala.
Ulagala. It's a saying we had in Cyprus championship. That means everything is okay. I would like to say from my experience as a medic and a nurse and practicing in free diving, that standardization and the creation of the algorithms will give a language, the same language we all can speak. Because when you are a medic and you try to explain to someone that it's not in the medical field and it's a free diver and it's doing safety, when you give him something materialized to read and understand and explain him in a second time, he will understand if you talk the same things every time. When somebody says blackout and somebody understands something different, it's a problem. So what I want to say, it's in my field in the hospital, we have the PHTLS, the ELS, the BLS, which everybody speaks the same language. So I believe here also the most important thing is that everyone will speak the same language, and I believe it's a step forward for the free diving community. That's what I want to say. I want to say hi to my friend and have a good continuance.
Thank you, George, for your kind words. But you're exactly right. It's just a way to universally understand one another. Medical teams consist out of multiple nationalities. Competitions take place all over the world. So having a language that is understood by everybody involved, in this case in incident management, is highly beneficial indeed. So thank you, George.
Anybody else has a question for Jeroen? We've held him almost about an hour now. I hope everybody has enjoyed, but please, Jeroen is a plethora of information. So if anybody else has a question, go ahead. If not, what time is where you are right now, Jeroen?
I don't know how long you said just an hour, then it's now 7 p.m.
Gotcha. Question to you: do you feel that? So, how many? Again, I want to make sure how many blow tap talk would you do? Would you recommend before getting the diver out of the water? If you are in, let's say, in a boat or a platform, and how many rescue breaths would you say you would do before you start other procedures? Is that 3 times or 5 times? Because I hear that from different camps, 2, 3, or 5. What do you think?
Well, point of view of in water protocol, I would just, if you remove facial equipment, you have the diver in your arms. He's in your arm pit, in your elbow. So removing facial equipment, facial gear, and talking directly towards this person's head, that's your blow tap talk. You don't need to execute some slaps in the face. In my opinion, that's rather traumatizing even. You just, those few seconds, if there's no reply, you have an unresponsive diver, you would immediately administer 2 rescue breaths on the nose, on the mouth. If then again, there's no reaction, you don't know the underlying cause of the fact that there is no reaction. So after 2 rescue breaths administered directly, you should already be moving towards some kind of medical assistance, in my book. If it's a competition, it's really nearby. And so after the 2 rescue breaths, you can do the, how do you say it, the transfer towards the on-land medical team rather fast. If you have a situation in the blue hole, it takes you about 4 minutes, 3-4 minutes, even not, to go to the shore.
Probably less.
Maybe I would give, it all depends on where you are. If you are, I'm not saying that giving an extra rescue breath isn't useful. It's very circumstantial dependent. But I would say no blow tap talk, just facial. If you call out the diver's name, you remove the facial equipment, that is a blow tap talk. And then 2 rescue breaths and start moving, go fast. If you have to do a 100-meter tow towards the shore because your target depth was really out of the shore, of course you can pause to take a breather and you can give again some rescue breaths and continue your tow. It's really circumstantial.
Yeah, I feel like the top part of the blow tap talk perhaps sometimes can put more water into the diver's face and can send feedback to brainstem and tell your brain that you're still underwater. That's why lots of people went from blow tap talk to just blow talk, instead of tapping. But that's a big topic of discussion in the whole community.
If you execute the maneuver correctly, the diver's head is right next to yours. So all that you do is breathing, is blowing, is talking, is touching. So you don't need a principle or a protocol that has a special name, because then people will start repeating it. And that's where the flaw is, in my opinion. Blow tap talk, okay, but the flaw is in the fact that people keep on doing blow tap talk again and again and again, and they lose time.
Correct.
So that's an awareness that needs to change, in my opinion.
Gotcha. Looks like we don't have any more questions, so we're gonna start wrapping up. And Jeroen, you've been amazing at enlightening us, all of us, with your material. This is amazing, and I feel like it's going to make the community and the sport safer. We're going to record this and we're going to put it on YouTube, and then we're going to be doing another episode of this virtual Congress in a week, next weekend. And I hope to see you all there. And thank you. I think it's a great initiative for all of us to sort of speak the same language and have a unified front on how to treat injured divers, especially injured divers in freediving, where our community has such a big sense of community that all of us is almost like a family. Thank you, Jeroen. Thank you so much.
My pleasure. Thank you for listening. I hope it wasn't too boring. I really try to have a broad vision on the whole diving community. So thank you again.
It was amazing.
Thank you very much.
Thank you, everyone. Cheers.
Thank you so much.
See you guys.
You guys have a great day.
Good job, guys.
Attending and
Thank you so
listening.
much.
See you next
See
week.
you around. I'm logging off.
Thank you. Cheers. Bye-bye.